Okay, well, thanks, Janice. Well, Janice challenged me with a very tough task, for all of us, in fact, which is in 5 minutes to cover a large field. And so I'm going to give you some random musings about a large pain problem, neuropathic pain. I'm a neurologist and direct a few divisions here, including the Neuromuscular Division and the Neurophysiology Laboratories. You've already heard plenty about the scope of the problem, and there's some wonderful quotes from the literature about the problem of pain. Now, to put neuropathic pain in some perspective, any of you in the room who are now crossing your legs and have that very bothersome pins and needles tingling, burning in the foot, multiply that sensation by about 100 and imagine it going on 24 hours a day. And that's the beginning of the sense of what these patients are experiencing with neuropathic pain. And here's this little diagram of somebody stepping on thumbtacks, and people often use that descriptor. Again, a running theme you've heard from virtually all of the speakers is the scope of this pain problem. And let me just highlight a couple of issues that are particularly relevant to peripheral neuropathy or neuropathic pain. This is a disease of the nerve endings, those wires that conduct electricity that allow us to move and feel. It's under-assessed. And assessment is critical. And as we think of app applications, we have to think of how can we figure out what's going on and how do we measure it. The patient is not believed. Think of pain. The only way we know how much you hurt is saying, "Doc, I hurt." And that's a problem because we really have difficulty measuring it objectively. We often don't understand the mechanisms. Treatment is inadequate. And even with treatments proven to work, they vary both within a given patient and certainly between patients. Again, a major issue with pain is the fact that it is subjective. And there's a wonderful quote from someone with an interesting name, Elizabeth Scarry. To experience pain is to have certainty. To hear about pain is to have doubt. We often don't believe our patients, and that's a problem. Now, this is a busy slide, but in this 5-minute talk, I use it to really show you the scope of the problem and some of the nomenclature that we use to define pain. And the two categories, and there's many ways of skinning this cat, but one way is to divide nociceptive pain on the one side versus what I'm focusing on is neuropathic pain on the other. What's nociceptive pain? That's pain caused by damage to tissue, post-op, arthritis, sports injury. Then we have neuropathic pain. This is pain that is due to a disease of the nervous system. It could be central in the brain, such as post-stroke pain. People with stroke can have pain. Or it can be in the peripheral nerve, such as neuropathy, diabetic, HIV. Now, many patients are mixed, and they fall into some combined category. And notice one disease falls into both groups, and that's probably one of the single greatest pain problems is low back pain, which I suspect everybody in this room has experienced. Now, one of the classic models or paradigms of this so-called neuropathic pain is peripheral neuropathy due to diabetes. A huge problem, depending on how you cut the numbers, anywhere from 20 to as high as 50%, if you look very carefully, of diabetics have neuropathy. What do they complain of? Pain, pins and needles, sensitivity, numbness, loss of balance. It's worse in the feet, and it moves up and then involves the hands. It's often called a stocking and glove neuropathy. Again, a unifying theme we've heard from all of our speakers, and certainly our patients tell us this, is treatment is not very good, and it's not handled well by most physicians. And virtually every society has come up with statements saying we need to do better in treating these patients. Now, how do we talk about treatment? Well, there's a huge challenge in thinking of reducing pain. we're talking not just about pain. If someone says, I have pain of 10 over 10, we're not going to get them down to 0. That's almost impossible. But what we want to do is look at improving quality of life. And when we think of assessment, one of the interesting considerations is how do we measure quality of life, and how do we measure people are really getting better? I can tell you that hundreds of millions of dollars are spent by pharma industry every year on pain trials, placebo-controlled, and many of these trials fail. Why? Because the outcome measure may not be as good as it can be. Improving physical functioning, including sleep, which is a big problem. And of course, we've heard from several of the speakers, pain is more than a physical component, but there's an emotional component as well, and a psychologic. And we need to think of all those domains as far as treatment. So to finalize, I've got several members of my team here, and in fact, I would highlight the fact that several of the group have already begun to embark on app development. And in our strategies, and we'd love to talk to some of you more about it, one of the key issues that we're focusing on is how to properly assess pain, how to record it, how patients report it to us, both in the clinical arena and in the clinical trials arena, because until we could figure out how to track, measure, assess, we're going to have a hard time treating it effectively. So with that, I'll leave it, and hopefully we'll have more time to talk.